All right. Hello, guys. So this will be kind of on the shorter side. Basically, hypertensive disorders of pregnancy is a pretty broad topic, but I'm going to be focusing more on the hypertension aspects of it, especially because we're going to be having a dedicated section for magnesium therapy later. So we'll talk about that. So essentially, just to give you guys a little bit of a background that Alyssa kind of explained, and Serena also kind of described. So we've been doing these Thursday morning sessions with UWOBs, and with this plan to kind of shift our practice model to including diabetes management intrapartum, as well as severe hypertension and preeclampsia with severe features potentially. With OB consults, we're doing this kind of series of learning sessions. Again, I took this from Alyssa's slides previously. We're trying to focus more on intrapartum management. I feel like we all have a pretty good grasp of like the screening, diagnosis, antepartum management, or induction timing. And like we kind of highlighted last time, we're talking about intrapartum GDM management, hypertensive disorders management, and in later discussions, we'll talk about the Meritor protocols and order sets specifically. Something else, I guess, to bring up with this is that I think it was Janine Barnes that had sent out an email about SharePoint. I would definitely recommend you guys to get access to that. I emailed her back and it was pretty easy. It basically has all the Meritor protocols for OB really nicely laid out and easy to download. Something else that Alyssa and I are also working on for some of the later sessions when we're going into the actual like management decisions and order sets is we're going to work on Google Forms to kind of have cases for you guys to go through and do some teaching that way. And then there's also a really great Meritor module for severe hypertension and preeclampsia with severe features that I'll also be sending out when we get to that point as well. So maybe some stuff for you guys to work on for next time is getting access to SharePoint. So basically moving on to our schedule. So specifically today, we'll be talking about hypertensive disorders. I did choose to focus more on blood pressure control specifically, which we'll talk about in a little bit. For March, we'll be going over, the management of insulin drips intrapartum, the hospital protocols and order sets, doing order sets for antihypertensives in April, and then May is the big kahuna where we'll be talking about magnesium and that sort of thing. So just a really quick review from what Alyssa talked about last time with her great presentation. So in terms of intrapartum GDM management, there's really a lot of mixed lit out there in recommendations. ACOG does recommend for pre-gestational diabetes, they don't have recs on GDM, but an intrapartum goal of less than 110. A couple more international societies have recs of 72 to 126. Meritor specifically has this goal of 70 to 110 intrapartum. During early labor, you check glucose every 2 hours and then every 1 hour during active labor. And then the decision to start IV insulin is when you're in active labor and blood sugar is greater than 110 and you stop at delivery. So going on to what we're going to talk about today. So basically, we'll be looking at some current literature within society guidelines, summarizing protocols, and then the last two we'll talk about at our next session. So, this is obviously a very broad topic to speak on. I really wanted to focus on intrapartum care, which is one of the big things that we're talking about. And I thought we'd talk about the historical context of our blood pressure goals and where it's been in the past and what the current recommendations now and kind of why 160 over 110 was decided to be this magic number for severe hypertension in women in pregnancy. Kind of looking at, the recent ACC and AHA updates, whether that has any, manifestations for our patients that are pregnant, as well as potentially how that could implicate or cause, I guess, newer blood pressure targets. It's also important to consider when we're managing severe hypertension, we don't want to drop the blood pressure too low because that can affect uteroplacental insufficiency and cause, adverse fetal outcomes. But obviously severe hypertension, which we'll talk about in a bit, can cause adverse maternal and fetal outcomes as well. So it's kind of that fine balancing act. So talking about kind of the definitions of hypertension in pregnancy, these are very broad. So the ACOG definitions, as well as SOGC, which is Canada, SOMANS, which is Australia, New Zealand, and RCOG, which is in England. Generally, the numbers hypertension in pregnancy is a blood pressure greater than 140 over 90 or equal to, and then severe hypertension in pregnancy is greater than or equal to 160 over 110. There are differences in intervals, like for example, gestational hypertension is within a 4-hour difference between the two numbers. I think it was for SOGC, it's like a matter of minutes. If you have, two blood pressures that are 140 over 90 or greater, that causes you to meet gestational hypertension. There's also kind of a breakdown of mild, moderate, and severe. So mild is 140 to 149 over 90 to 99. then moderate is 150 to 159, over 100 to 109. But I would say across the board, consistently across international organizations, these are the numbers that we're looking at when we're thinking about hypertension in pregnancy. Something to keep in mind is that these are not taking into account the AHA and ACC 2019 updated guidelines that say, for non-pregnant individuals, blood pressure goals should be 130 over 80 or less. And, we obviously as family practice docs, I think for the most part are sticking with the AAFP recommendations of still using 140 over 90. But as we'll talk about in another slide, OB may be, depending on how the results of one of these studies go, maybe thinking about that or addressing that in the future. So I wanted to talk next about this study, and this was a study that was done in 2005. And maybe some of you guys that have been practicing OB for longer than I have on this. When I was doing kind of looking into research and studies about, why do we choose 160 over 110 as the marker for severe hypertension? It sounds like, maybe like 15, 20 years ago, experts and OB providers and were using diastolic blood pressure is more of an indication of whether to treat, whether that had implications for stroke. And so antihypertension meds were typically recommended for an elevated diastolic blood pressure, was my understanding based on my reading the past couple of days. Systolic blood pressure, I would say 15 to 20 years ago, wasn't as explored as, a potential indication for stroke. In 2000, the NIH had a working group on hypertension in pregnancy, and they, in that report, had talked about how some providers were treating for diastolics of 105 or greater, some were treating for persistent diastolics of 110, but ultimately decided, the 160 over the 110 was the indication for severe hypertension. But this study that was published in ACOG in 2005 basically looked at 28 patients. It was a case history review that sustained a stroke, specifically in association with severe preeclampsia and eclampsia during this time period in Mississippi. I think there was like 300 or 400 odd people that had strokes in general, but then specifically related to preeclampsia and eclampsia, it was about 28 patients. Stroke occurred antepartum in 12 patients, postpartum in 16. They did identify this kind of subsect of 24 people that were being treated immediately prior to the stroke, and so they had blood pressure data for them. And in 23 of those 24, the SVP was 160 or higher, and then more than 155 in 100%. And that one patient that had a systolic of 155 and not 160, unfortunately, had that systolic blood pressure at home, was in the ambulance on the way to the hospital, sustained a stroke in the ambulance en route to the hospital, and then on admission to the hospital had a blood pressure that was, I think, 162 or something. So clearly some, association there. They did interestingly note that only 3 of the 24 patients had diastolic pressures of 110 or greater, and only 5 reached 105. So this was a study that I think contributed to that paradigm shift of looking more at systolic blood pressures as potentially an indication for risk of stroke. And I think, was one of the times that was really enforcing people to, we should take the systolic blood pressure more seriously potentially than what we had anticipated before. Another study kind of along the same lines, this was a study that was published in ACOG in 2019, basically supporting the idea that systolic blood pressure is potentially an indicator for adverse maternal as well as fetal outcomes. I think this one was specifically looking at maternal. Basically a retrospective review study looking at preeclampsia-related deaths. So 333 deaths total, 54 of those that were attributed to preeclampsia and eclampsia, and of those 54, 33 were due to stroke. And so they broke that data down into various demographics, and then 26 of those 33 stroke cases had blood pressure info available. And so in 96% of those cases, the SVP was greater than 160. In 19 out of those 26 cases, the diastolic blood pressure was greater than 105. And in 17 out of those 26 cases, it was greater than 110, so 73% and 65% respectively. So just another study that potentially is at that time was indicating, or I guess more recently indicating, that systolic blood pressure is something to seriously consider when thinking about adverse maternal outcomes. And then the third one that I wanted to bring up, so this was a retrospective cohort study. It was published in AJOG from 2012 to 2014, basically looking at women that delivered in 15 hospitals in California, and it basically looked at other maternal outcomes other than stroke in relation to severe hypertension. They looked at severe hypertension versus non-severe hypertension, which was the control, as well as other maternal outcomes outside of stroke. Interestingly, they called severe hypertension a systolic of greater than 160, but diastolic greater than 105. And this was due to, I think at that time, there was like a collaborative care cohort in California, and that was based on their evidence that they were using a diastolic of 105, even though this does differ, ACOG's recommendations. Basically what it showed is that, 2252 people had severe hypertension. The control group had 93,650. They did note that there was a significantly higher, both statistically as well as, just regular verbiage, but severe maternal mortality that was higher in the severe hypertension group, so 8.8% versus 2.3%. They noticed significantly higher differences in pulmonary edema, ARDS, transfusion, ventilation, postpartum hemorrhage, as well as placental abruption. Interestingly, in this study, stroke was not significantly different, although there was definitely an increase in frequency in the group with severe hypertension, but I think the p-value is basically trending towards significance, so something else to consider. And then this is kind of an interesting study that I had found. This kind of delves a little bit more into kind of antepartum surveillance. So it's the CHIPS RCT trial. It was published in 2006. So it was a randomized open-controlled multi-center international trial, basically enrolling women with chronic or gestational hypertension, and they were randomized to a left tight blood pressure target, so a diastolic. They used diastolic in this case of 100 versus tight control with a goal diastolic pressure of 85. Their primary outcomes were pregnancy loss or high-level neonatal care for 48 hours, I think within the first month, as well as low birth weight, less than a 10th percentile, and then looked at maternal complications as a secondary outcome. It basically looked at kind of like any things that we can determine as to when to intervene to control high blood pressure. And so in the less tight control group, there was a significant difference in the sense that the less tight control group more frequently developed severe hypertension. And they were able to say, severe hypertension was associated with higher rates of primary perinatal and secondary maternal outcomes, but these rates were actually pretty similar in both groups and wasn't significant. So this study, I think, was kind of controversial because experts kind of differ in how they can interpret this. And so the deficits from this trial actually are hopefully going to be addressed in this upcoming trial called a CHAP trial. I think it's a trial that's currently in progress, and I think it would be a really good journal club for people that are OB inclined in the future when it comes out. Basically, it's the Chronic Hypertension and Pregnancy project. It's a large multi-center RCT that's currently in progress. It's looking at pregnant patients with chronic hypertension, basically deciding, if we try to achieve blood pressure goals of less than 140/90, so what we do for the general population in a pregnant patient, if we compare that to kind of the ACOG recommended standard in pregnancy, which is no treatment unless your blood pressure is severe, which one is kind of effective and safe, or is one, inferior to the other? So basically there'll be an antihypertensive arm with the goal of maintaining the blood pressure less than 140/90. There'll be another arm that'll have kind of a less tight goal of less than 160/105. And those people will not be on any medications, or they'll be on a low enough med to just get them under that threshold. So nothing like a big significant drop. It's interesting because it's kind of, like I said, balancing the uteroplacental flow versus, blood pressure control. And I think it'll be interesting to see where this goes because they've already commented, there's some talk out there of whether this will have implications for, further ACOG guidelines as to recommendations for antepartum control of blood pressure in the future. Like, are we going to shift more towards, the ACC and AHA guidelines in general versus having the current recommendations stand? So I think this was started a couple of years ago. Last time I checked, which was I think the past couple of days, it still is in process, but I think this is something that we should be keeping our eyes out in the future because it certainly could have implications for how we manage hypertension in pregnancy. I promise not to get too antepartum, but I thought this was an interesting thing to include as well. So basically going to the current Meriter guidelines, and this is really just a summary. We'll go into way more detail at an upcoming lecture. But basically, if a patient comes into triage, for example, and it has an initial blood pressure of greater than or equal to 160/110, the protocol really is to repeat that in 15 minutes, make sure that there's an appropriate size blood pressure cuff, they have tapes to measure, making sure that the method of taking the blood pressure is right. So if they're sitting in a chair, feet on the ground, not cross-legged, all the things that we we know as good family med docs. If that blood pressure is still persistently elevated after 15 minutes, technically a news page should be given out. And then the recommendation for Meritor is that we do need to give a med within 30 to 60 minutes of a documented severe range blood pressure, which makes a lot of sense. As part of the order set, the 3 first-line agents, and these are pretty consistent with ACOG as well, is IV or labetalol or hydralazine, or PO nifedipine immediate release. Something to keep in mind is that, and I think we all know this, but magnesium is not an antihypertensive. Unfortunately, in some of these studies that I looked at, they did comment on the delay of giving antihypertensives, and it seemed like a lot of priority was given to starting the magnesium, for example, but not necessarily giving an antihypertensive. And women unfortunately suffered strokes because of that. And so that's something to keep in mind. It's for kind of balancing 2 things, right? We're managing hypertension as well as preventing seizures, which is what the magnesium is for. A little note on hydralazine, it may be falling a little bit out of favor. There's been no changes to ACOG's guidelines, but there are some studies out there that show that it may too drastically drop the blood pressure and can affect uteroplacental blood flow. And so keeping that in mind, it's still first line and it's still part of our order sets, but I think there are some studies in the future that may have implications for the use of hydralazine in the future. And then the actual order set is titled Emergency Therapy for Acute Onset Severe Hypertension Obstetrics, and that's the order set number as well. But we'll go into this in more detail at our next session. We'll have, I'm anticipating like photos of the order sets and the slides and that sort of thing so you guys can see it and how it looks like in real time. And I think that's all I have. Hopefully people aren't going to run to clinic too late. But next session, and I guess it'll be in 2 sessions from now, again, we'll talk about the current Meritor guidelines in depth. We'll go over order sets and doses and documentation. And I'll also share with you guys the hypertension, preeclampsia, and eclampsia training module that I thought was really well done. And I think that's all I got.